Hello, this is Stephen Holloway. Today we'll be talking chronic kidney disease. This is part of Nursing 202, Module E. And we look at chronic kidney disease. We're going to look at the definitions, etiology, incidence and prevalence, pathophysiology, and the stages. Chronic kidney disease is defined as a progressive, irreversible disorder of kidney function that does not recover. When kidney function is too poor to sustain life, chronic kidney disease becomes end-stage kidney disease. Terms used with kidney dysfunction include azotemia, which is the buildup of nitrogenous waste in the bloodstream, uremia, which is azotemia with clinical symptoms. Chart 71-4 in your book will give you clinical symptoms of uremia that you should be aware of. 90 to 95% of nephrons must be destroyed before the kidney dysfunction is noted. Incidence and prevalence of chronic kidney disease, based on 2010 U.S. Renal Data System's annual report, says that 527,000 plus people in the United States were under treatment for end-stage kidney disease. In 2007, the reported incidence of kidney disease, new patients per year requiring renal replacement therapy, was close to 110,000. So 110,000 people each year, new patients are added to the rolls. More than 24% of patients with end-stage kidney disease die during the first year of treatment. End-stage kidney disease occurs more often in more often in men than women, and the greatest increase in end-stage kidney disease has been in patients 65 years or older. If you will look at this table, this looks at the etiology of kidney disease. We've talked about several of these as we've gone through our lecture process, but these are some of the disease processes that will lead to chronic kidney disease. Glomerulonephritis, basement main membrane, Goodpasture syndrome, intracapillary glomerulonephritis, chronic hypercalcemia, chronic potassium depletion, heavy metal lead poisoning issues, ischemic disease of the kidneys, bilateral renal stenosis, obstructive uropathies, polycystic kidney disease, pyelonephritis. All of those can lead to some of those issues that we see. Systemic vascular diseases such as intrarenal renal vascular hypertension, regular hypertension. Metabolic diseases such as diabetes and hypertension can cause issues with those, and connective tissue disorders, especially as we look at systemic lupus erythematosus. All can be causes or etiologies of chronic kidney disease. Now, the pathophysiology of chronic kidney disease is different depending on which disease process. The big thing is all of these lead to the destruction of the functional unit, the nephrons of the kidneys, and basically what happens is there's just not enough nephrons to process all the nitrogenous waste and to control the fluid balance and electrolyte balance. And we'll talk a little bit more about that individually as we look at it. Now let's look at the stages of end-stage kidney disease as we look at it. Stage 1, the person's at risk. They really have normal kidney function. Early disease may or may not be present. Their glomerular filtration rate is still normal, greater than 90 milliliters per minute. These patients, though, we need to make sure we're looking for those disease processes that can cause long-term kidney disease, chronic kidney disease. Things such as hypertension, making sure we're controlling the hypertension. Diabetes, anyone that's having chronic kidney or urinary tract infections. The presence of genetic kidney diseases, exposure to nephrotoxic agents. People who work in factories or in businesses with heavy metals, those type things may be more prone to development of chronic kidney diseases. Stage 2, damage has begun to take effect. We're seeing a loss of nephrons. Our GFR has dropped to 60 to 89 milliliters per minute. The focus in interventions on these is the reduction of risk factors. Stage 2 is also called mild. And the kidney nephrons are damaged. It has occurred. You may see a slight elevation of metabolic waste in the blood, so you'll see a rise in the BUN and creatinine on these patients. May not be much, but it'll be a little bit. But there are enough healthy nephrons still left to maintain a normal life for these patients. These patients, though, need to be aware that they've got some drop in their kidney function. Any of the acute cap injury problems can put these folks over the edge and put them into big issues. One of the things we need to teach our patients with mild kidney disease is managing their fluid volume, managing their blood pressure and electrolytes, and any other damaging diseases, especially if they have hypertension or diabetes. We need to make sure we maintain that blood pressure at a good value, and we need to maintain that diabetes with a hemoglobin A1C less than. Basically, we can slow down this progression. We can keep these folks at a healthy level if we maintain these processes. We want to make sure they're following prescribed drugs for hypertension, diabetes, and any nutritional therapy that may be there for these patients. These are some of the things that we need to be teaching our patients that have stage 2. Now, stage 3 is a little bit worse, moderate kidney disease. You can see that the estimated GFR has dropped from 30 to 59 milliliters per minute. We've got to implement strategies to slow down the progression of this disease at this time. Nephron damage has continued. The remaining nephrons can't manage the metabolic waste as well as they could, so we may begin to see problems with fluid balance, electrolyte balance. At this stage, we may be restricting fluids and proteins and electrolytes as needed. So these patients are moving more toward progression, more toward the severe and end-stage problems. Now, stage 4 and 5, severe and end-stage kidney disease, you can see there is a consistent drop in the glomerular filtration rate. These patients are getting more and more complication, and we need to, once they dropped into that stage 4, we need to be teaching them about eventual renal replacement therapy. Should have started in stage 3 looking at that, talking about that. These are the things that are going on. This is where you're moving. But once they hit stage 4, we've really got to start talking to them. This is the time, if they're going to do dialysis, maybe to start talking to them about the different types of dialysis shunts that will have to be put in place, whether they want to do hemodialysis or they want to do peritoneal dialysis. Because that movement from stage 4 to stage 5 can occur very quickly, and we want to make sure that we're aware of what's going on there, aware of what's going on, and getting them ready in case those kidneys do really shut down and we see a GFR less than 15. Once we get to the GFR less than 15, we have to implement renal replacement therapy, which is dialysis or kidney transplant at that point in time. But when they're in that 4 stage, they cannot maintain homeostasis. We're seeing excessive amounts of BUN creatinine going up. We may see changes in the sodium and potassium levels, as well as calcium and phosphate levels. Once they reach that stage 5, unless we do dialysis or we do a transplant, these people are going to die from this type of process going on. So when we look at chronic kidney disease, we need to look at the metabolic and electrolyte changes that go on. We're going to talk about the BUN creatinine, sodium, potassium, acid base, and calcium phosphate. Now, when we talk about BUN and creatinine, the urea and creatinine excretions are disrupted by the kidney functions. This is the nitrogenous waste that begins to build up. Creatinine is a breakdown of the muscle tissue, and as it progresses, the kidneys are less able to take care of those type processes. Now, with sodium, early in chronic kidney disease, the patient is at risk for hyponatremia or sodium depletion because there are fewer healthy nephrons to reabsorb the sodium. So the sodium is actually lost through the urine, and because of the loss of sodium, fluid is also lost. So we may see polyuria in these patients in the early stages of dysfunction of the kidneys. In the later stages, the kidneys Excretion sodium is reduced as there's less nephrons to work, so we begin to see sodium retention. So we're seeing hypernatremia. But we're also seeing, because of the hypernatremia, we're seeing fluid retention as well. So even though we may have a high level of sodium in the vascular space, we may not see it when we look at our serum labs because of the dilutional factor from the fluid retention that's going on. The problem basically leads to severe fluid retention, electrolyte imbalances. Remember, sodium tends to affect your brain more than anything, so we may be seeing some encephalopathies going along with the sodium issues that go also with the uremia that goes on with the BU and creatinine. Potassium excretion occurs mainly through the kidneys, and we know that already. Typically, an increase in potassium load we see during the later stages of chronic kidney disease, leading to hyperkalemia. These high serum potassium levels can lead to cardiac dysrhythmias. We have to be very careful in these patients in monitoring them for dysrhythmias. The dysrhythmias can be the cause of death in many of these patients. So monitoring them for cardiac dysrhythmias. Also looking for the muscle issues that go along with the hyperkalemia as well. Now, acid-base, again, the kidneys are the major process in controlling bicarb and hydrogen ion concentrations. With chronic kidney disease, the kidneys can't excrete the excessive hydrogen ions. They're holding on to that, which increases acidity. Also, can't reabsorb the bicarb ions, so we're losing the bicarb, which again leads to that metabolic acidosis type problems. Because of that, you may see the respiratory system trying to compensate with faster and deeper respirations. Treatment, a lot of times there may be some alkali replacement for these patients. Now, calcium and phosphorus in chronic kidney disease, phosphate retention is a big problem, and these patients also tend to have a deficiency of active vitamin D, which disrupts the calcium and phosphate balance. Normally we see an excess of dietary phosphate is excreted in the urine, but because of these chronic kidney disease, that can't happen in those. So we see an increase in phosphate levels, hyperphosphatemia, and as that phosphate goes up, the calcium levels decrease. And as we see those calcium levels decrease, we see the parathyroid hormone kicking in, and calcium is released from the storage areas in the bones to bring that back up. So because we're seeing the calcium leaving the bones, we're seeing these patients become actually getting osteomalacia. We may see some osteodystrophy from these patients. So these patients are at risk for fractures, especially the spinal cord and those things. You may also see loss of calcium from the teeth. So something to watch for in our patients with chronic kidney disease. Now, as we look at the clinical manifestations and the pathophysiology of our patients with chronic kidney disease, neurological management, which is related to the buildup of the uremia and also the sodium type issues. We may see lethargy, daytime drowsiness. These patients may have the inability to concentrate or may have a decreased attention span. Seizures, coma, slurred speech are all problems that we may see, even ataxia and paresthesias. The big problem is this goes along and it's untreated, is encephalopathy. And it's the encephalopathy that leads to the seizures and coma. If dialysis is used, we get the sodium levels and the uric acids back into normal ranges. The encephalopathy will resolve and these patients will get better. So the neurological, we need to make sure we're assessing our neurological status on our patients, looking at changes in mental status for these patients. Cardiovascular is a big issue for these patients. Again, many of these patients already have cardiac issues before they even get into chronic kidney disease, especially if they have a history of diabetes or hypertension. So this is only going to intensify the cardiac problems they have. Cardiomyopathy is typically going to occur because of the increased workload of hypertension. Again, hypertension may get worse because of the retention of fluid and sodium in these patients. Because of the fluid excess, we're probably going to see some peripheral edema. We may even see pulmonary edema on these patients as we see the fluid move into the lung areas as well, and we'll develop heart failure for these patients. Uremic pericarditis is something that can occur. It occurs in patients with chronic kidney disease. The pericardial sac actually becomes inflamed because of uremic toxins. If not treated, it leads to a pericardial infusion, which leads to cardiac tamponade, which can lead to death in these patients. So need to be aware. When we're looking at the pericardial effusions, we may hear a pericardial friction rub. These patients will need drainage of that infusion to allow the cardiac muscle to expand to work for that. So make sure you're assessing your patient. You're listening for S3s, which can indicate increased fluid volume and movement toward congestive heart failure, and listening for that pericardial friction rub, which can indicate that pericardial infusion and pericarditis for these patients. Also, make sure you're assessing the rate and the rhythm. We talked about the hyperkalemia, which can lead to dysrhythmias on these patients. So we're going to be monitoring their cardiac rhythms, typically by telemetry, but also as you're looking at these patients, as you're taking your vital signs, check for those dysrhythmias, those irregular rhythms, as we're looking at these patients. Again, hypertension may be a big problem with these patients, so giving the medications that are needed to control that hypertension. ACE inhibitors tend to be the drug of choice. Calcium channel blockers are also used because of the changes in calcium in these patients. So be aware of the different medications that are being used for these patients. Now, respiratory manifestations, these patients may have a uremic halitosis, in other words, a bad breath related to the buildup of uremia in the system. The rates, you may see tachypnea and deep sighing, yawning, Kussmaul respirations. That goes back to that acid-base balance, and the respiratory system is trying to compensate for the acidosis by fast breathing, deeper breathing to blow off the CO2 to control that acidosis. So that's not uncommon with these patients. Again, they may develop a pneumonitis because of the uremia. Shortness of breath, pulmonary edema are all possibilities because of the fluid retention on these patients. So you may hear crackles. You can also get a pleural effusion, which is fluid between those two layers. So you may hear a rub, pericardial friction, a pleural friction rub as you listen to these patients as well. So be aware of all those changes that may go on with these patients. Hematologic is another big problem that we see. Anemia is typically one of the big problems. Many times these patients are getting erythropoietin to boost their red blood cells. The erythropoietin can be given before they begin dialysis. Once they begin dialysis, the erythropoietin is typically given as part of the dialysis procedure. Now, be aware that these patients also get breakdown of the red blood cells, so we can see problems with that. These patients many times will require transfusions as part of the dialysis process. Iron is very important in these patients, but they have a hard time taking those because there's also changes in the coagulation process and platelets. These patients may have abnormal bleeding and bruising. We want to make sure we're checking the skin for any excess bruising, especially checking the gums. Talking to them about black tarry stools. If we see any of that, that can lead to can be an indication of a GI bleed on these patients. But be aware of the anemia, because this anemia is probably going to cause these patients to feel fatigued, weak. It may even lead to some shortness of breath because of the lack of oxygen carrying capabilities of the blood. So make sure that you're doing that. One of my colleagues is doing a study looking at adding iron to these patients who are getting dialysis versus just using erythropoietin to see if we can increase the oxygen carrying capability of the blood. GI also is affected. Every system is affected by chronic kidney disease. These patients are typically anorexic. Because of the fluid overload, because of the toxic waste, they just don't feel like eating. Nausea and vomiting is very possible. They may talk about this metallic taste in their mouth, which leads more to that anorexia. They may experience changes in taste, acuity, and sensation, so that's not uncommon. All that leads back to that anorexia, and then the possibility of nutritional deficits on these patients. They can develop uremic colitis, which leads to diarrhea. They can have uremic gastritis, which can lead to GI bleeding. Again, we talked about the bad breath. It's not only from respiratory, but it's also from the GI tract. And these patients will complain of a lot of stomatitis. So not only do they not feel like eating because of anorexia, now it hurts to eat because of the stomatitis in the mouth. Peptic ulcer disease is very common in these patients. Exact cause is really unclear, but beware that is a problem with that. Beware and watching for those dark tarry stools on these patients, as that risk of GI bleed is greatly increased on these patients. So monitoring that GI tract, assessing your patient's abdomen, listening for your bowel sounds, checking the stools, all of that assessment is very, very important in these patients. Of course, urinary manifestations, typically early chronic kidney disease, you may see polyuria and nocturia. But as we move toward end-stage kidney disease, we're going to see oliguria, anuria. Of course, the protein in the blood and the urine we're going to see. As we move toward the later, the urine is going to be very concentrated, very cloudy, as we're holding on to all the fluids and everything that's going on. Skin's also affected because of the fluid overload. You may see a decrease in skin turgor. You may see a yellow-gray pallor on these patients because of the breakdown of the red blood cells and changes going on in the liver. The biggest thing is that uremic frost, which occurs very late. That, coupled with the dry skin, leads to pruritus, and these people will scratch, and excoriate their skin. So be careful and help them with those type things. Again, we talked about ecchymosis and purpura. Those type things can occur because of the changes in the platelets and the coagulation processes. You can see buildup of calcium in the soft tissue areas. Again, that's kind of a later sign. We talked about musculoskeletal because of the changes that are going on, because of breakdown of the muscle, because the body is beginning to break down the muscle to kind of help with the whole process. You may see changes in that. Bone pain because of the lack of calcium, pathologic fractures. You may see renal osteodystrophy is a good indication that's what's going on with these patients. So these patients need to make sure that, again, because of the fatigue, those type of things, they don't feel like doing anything. So just be aware of all of these as you're preparing your care on your patients. If this person is within the reproductive time frame in their life, we see decreased fertility. Women may have infrequent or absent menses, decreased libido, both male and female, and impotence in the male patient. Now, as we begin looking at managing these patients who have chronic kidney disease, the whole process is basically managing fluid volume, preventing complications of fluid overload, increasing the cardiac output on these patients, and then removing those uremic wastes and everything with these patients. Sorry about that. So those are some of the things that we're going to be looking at. As we look at maintaining this fluid balance and try to keep that fluid balance, drugs can be used, and fluid restrictions are definitely part of those. If you will look at table 71.8, it talks about nutritional and fluid restrictions for these patients. And the fluid restriction will be based on whether this patient is not on dialysis, whether they're on hemodialysis, or whether they're on peritoneal dialysis for these patients. If they're on hemodialysis, then we're looking at basically any type of urine output. Let me rephrase that. Stand by. Okay. As we look at these patients, if they're in diet, when we look at fluid with these patients with chronic uremia, it depends on how their output is going. You can see anywhere between 1,500 and 3,000 milliliters per day for these patients. If they're on hemodialysis, and basically what you're going to be giving is how much urine out, the total urine output, plus 500 to 700 milliliters a day for that. When we look at peritoneal, there's restrictions based on fluid and weight gain and blood pressures, and the physician will make that decision. You just have, the main thing for us as nurses is to help those patients with those fluid restrictions. Divide those up, use strategies to decrease fluid intake, things such as hard sugar-free candies, using ice instead of drinking water to moisten the mouth, the glycerin swabs to help moisten the mouth and the mucous membranes. All of those are very important things as we begin to do that. Now the drugs typically, to try to, because these patients are retaining fluids, we want to try to get rid of those fluids. Lasix is very rarely used in these patients because of the kidneys aren't functioning, and by using these diuretics such as Lasix, you can actually damage what few nephrons are left. Will it be used? Sometimes yes, sometimes no. Depends on what's going on with the patient, but be aware of those type things when you're looking at your patients. Now, prevention of complications of fluid overload, pulmonary edema is one of the big problems that we see. And again, maintaining that fluid balance. Sometimes Lasix is given for these patients, but again, it's more of a last-ditch effort. Morphine can be given, small amounts of morphine, 1 to 2 milligrams, which kind of helps with the whole process that's going on. But a lot of times these patients are going to be put on ultrafiltration. Ultrafiltration is a process of looks very much like hemodialysis, but instead of moving the electrolytes and the waste, all ultrafiltration does is remove fluid from the system. Now, we also want to increase the cardiac output on these patients. We want to control the hypertension. Medications, ACE inhibitors tend to help. They actually begin to bring down some of the BUN creatinine levels. Calcium channel blockers, almost any of the hypertensive agents other than your beta blockers, which are going to decrease your cardiac intensity, may be used on these patients to do that. Digoxin may be used in these patients. Be very careful in giving digoxin to a patient with chronic kidney disease because the digoxin is processed through the kidneys. You need to manage and monitor for toxic effects of digoxin on these patients. So make sure that, any medications we're giving these patients may be in a reduced dose because of the kidney failure. We need to monitor for signs and symptoms of toxicity from any of these medications. Now, the other thing that we talk about with these patients is enhancing their nutritional therapy. Table 78.1 we talked about already with the fluids, but protein's also an issue with these patients, as is your electrolytes, your potassium, your sodium, your phosphorus. So these patients are going to be limited on many of these processes as we go along. You can see the proteins depending on whether they're on hemodialysis or peritoneal dialysis or whether just in chronic kidney failure. Potassium, again, it's interesting with peritoneal dialysis, there's no restriction on the potassium. Sodium, again, needs to be restricted. Phosphorus, again, needs to be restricted, but phosphorus is going to also be a little bit restricted because a lot of the proteins contain phosphorus. Many times because of the phosphorus levels, these patients will be put on medications to block the uptake of phosphorus. So beware that may be medications. Those medications are usually given along with the meals when they take. These also help increase the amount of calcium for these patients as well. So those are some of the issues that you may see with the patients. Now, treatment, basically renal replacement therapy for these patients comes in the form of hemodialysis, peritoneal dialysis, and kidney transplant. Now, hemodialysis, basically we're going to look at the care of the patient. Chart 71.9 really talks about that, and then some of the complications, especially coagulation issues and disequilibrium symptom. Really want you to focus on that care of the patient 71.9 because that's really what I want you to understand. I don't know, right at this point, I don't care that you understand the whole process of the dialysis machine. Basically, do know that the patients are typically hooked up to these machines for 3 to 4 hours, depending on how bad they are. Typically go 3 times a week for these. There are home dialysis machines that can be used. They're used on a nightly basis. A lot of things are changing in dialysis. If you've not had the opportunity to go down to the dialysis unit and see this, this is something that I think you should do. Now remember, when we start looking at dialysis, we have to have vascular access. And typically what we do is we see either a hemodialysis, we'll see the placement of either a hemodialysis fistula, which is basically connecting as in an A here, as we see basically they're bring together an artery and a vein. Now we have to have enough blood flow from both areas. Have to have basically somewhere around 250 to 300 milliliters an hour of blood flow to maintain hemodialysis. And normal venous cannulation doesn't give us that high rate of blood flow. So this vascular access is formed by surgery, and so it allows for easy access. The two common choices for this access are internal AV shunts or AV fistulas or an AV graft. The graft basically uses a piece of cloth type. Is basically a graft that's artificial graft that's put in to allow that blood flow to go from the artery to the things. These do have to mature. And once they mature, you can see how these look for those. Make sure that typically they start lower in the arms if possible and then move up with these. Make sure that you are checking these on a routine basis. You're going to check the peripheral pulses, distal to the area, capillary refill in the arm with the fistula. Then you're going to check the fistula itself. You're going to check for a bruit, which is a swishing sound by auscultating over the access site, and then also feeling for a thrill, which is kind of like a vibration over the site. If you feel those, then that site is good and can be used. And we'll talk a little bit more about safety and quality, safety and taking care of those sites as well. When we look at taking care of those sites, 71-8 is best practices for patient safety and quality care of an AV fistula or AV graft. Do not take blood pressure readings using the extremity in which the vascular access is placed. Do not perform venipunctures or start an IV line in that extremity. Always palpate for thrills and auscultate for bruits every 4 hours while the patient is awake. Assess the patient's distal pulses and circulation in the arm. Elevate the affected extremity, especially as soon as post-operatively. Encourage routine range of motion exercises. Always check for bleeding at needle site insertions. Assess for manifestation of infection at access sites. And instruct the patient not to carry heavy loads or anything that compresses the extremity in which the vascular access is placed. All of those are very important for maintaining those. Now, many times the patients will go into total shutdown before these are matured, and these patients will require a temporary hemodialysis catheter. There's several different out there. You may hear something called an ash split catheter. They can basically have 2 or 3 ports. 2 ports are typical, and 1 port is for arterial, and 1 port is for venous. 1 is for basically extracting the blood, the other's for putting the blood back in. These can either go through the internal jugular or through the subclavian. It doesn't really matter. It's physician's choice for these patients. As a nurse on the floor or the ICU, my recommendations are do not touch this catheter. This catheter is basically property of the dialysis nurses, and they get a little upset if we as ICU nurses or floor nurses mess with their access, because this is the patient's lifeline as far as this basically is their kidney function. And if we do something to this and cause it to clot off, then that patient can't get dialysis through that time frame. So be aware, just like any other catheter that's inserted, watch for signs of infection. With these patients, typically, again, dialysis will change the dressings and do all of that goes on with those. But beware, looking for those signs of infection. Again, you may see a triple port. That triple port is so they can give medications during dialysis, give blood during dialysis. So you may see a triple port catheter as well. As we look at these, best practices and safety for a patient undergoing hemodialysis, these are pretty common sense things in taking care of any patient, but especially a patient with kidney failure. We're monitoring for fluid overload. So we want to weigh the patient before and after dialysis. Typically, we're going to see what the patient's weight is. We should see that weight go down after dialysis because we are pulling off fluids. We need to know the patient's dry weight. What we mean by that is basically when they're basically finished with dialysis. Talk with the healthcare provider whether the patient's drugs should be withheld until dialysis is completed. Many medications can be removed through dialysis. Your book has a chart that lists all those medications. I don't want you to right now know that chart. Because when your patient has medications, that's something you'll check. You'll look those drugs up at that point in time and say, all right, is this drug something that's going to be removed by dialysis? So that will be part of your checking with these patients and knowing which ones you were going to give before dialysis, which one you're going to wait until they get back from dialysis to give. Okay, be aware of the events that occurred during previous dialysis treatments. In other words, does this patient have any problem? Did they have to slow the rate down? Did they get nausea, vomiting? Did they get headaches? Did they have any problems with it? Of course, blood pressure, pulse, respirations, and temperature, always before they go dialysis, through dialysis, and when they get back. Once they come back, we want to assess for symptoms of orthostatic hypotension. Again, remember, we're removing a lot of fluids from these patients, and these patients may not have adapted to that. So beware and talk to your patients about. Don't get right up out of the bed. Sit up on the side of the bed, then stand up because of the possible orthostatic changes. Assessing the vascular access site, again, that's part of what we do on the floor. We're just checking it. We're feeling for the thrill. We're listening for the bruit. Because during dialysis, these patients have to be given heparin to prevent the clots from forming in the dialysis catheters and the dialysis filters. These patients are at greater risk for bleeding. So we want to make sure we're monitoring them for those. Remember that heparin has an effect of about 4 to 6 hours on these patients. So we need to make sure we're monitoring during that time, looking for any bleeding that comes along with these patients. Again, assess the patient's level of consciousness, assess for headache, nausea, vomiting on these patients. I know that when my wife did dialysis, when she finished dialysis, she always had a headache. She was very nauseated. She would vomit on the way home from dialysis. She did just not do well with dialysis. Typically, she'd come home and have to go to bed after dialysis. The next day, she'd feel a little bit better. The following day, when it was time for her to go back for dialysis, she was feeling much better. But then the whole cycle would start over again. Each patient tolerates dialysis differently. So you need to understand how your patient tolerates that dialysis for those. Again, many of the times these patients are in the hospital. Dialysis may, especially ICUs, may come to their room. If they're on the floor, they may be sent down to dialysis, and then it's our responsibility once they come back to the floor to monitor those type processes. Now, the other options patients have in dialysis is peritoneal dialysis. Peritoneal dialysis allows the exchange of waste, fluids, and electrolytes to occur within the peritoneal cavity. It is slower than hemodialysis. However, because of that, more time is needed to achieve the same effect. Many patients find this much more convenient because they can do this at home. They don't have to leave their home to go do that. They don't have travel distances to a hemodialysis site. That is a personal choice by the patients. The nephrologist and their team will actually talk to these patients really when they start reaching that stage 3 area about what types of processes they want to go. If a patient goes quickly into stage 5, many times they're going to have to put in that temporary hemodialysis until they can get things set up for this. It takes time to get that catheter in place, get everything there, get the training that goes on with these patients. So these patients, many times, if they go quickly from stage 3 to stage 4, 5, they may have to have temporary hemodialysis till all is set up for this peritoneal dialysis. Now with peritoneal dialysis, it's pretty straightforward. Your book has several graphics on that, but basically you have a catheter that's placed into the abdomen. It uses the basically because the peritoneal cavity is so rich in capillaries and basically and blood supplies there, the waste products move freely across. Dialyzed solution is put in, and this solution allows the waste products to be drawn into that area. Really what you're doing is using the peritoneal membrane as that dialysis type process. So this is the fluid is put in, it's left in for a certain amount of time, and then actually drained back out from the tubing. Now there's basically several types of peritoneal dialysis. There is an intermittent type dialysis where it's put in, the diacylate's put in, it's allowed to sit, and then drained back out into the bag. There's a continuous type process as well, and then there's an automated type process that the patients can do where the machine actually controls. Basically, this is usually a lot of times done at night while the patient is sleeping. The patient will hook themselves up. The machine will then continually circulate the diacylate solution through the system, and so when the patient wakes up in the morning, they just disconnect and they move on with their lives. Many people are choosing this because of the convenience at home. As I said before, things are changing in hemo. Now hemodialysis actually can be used at home as well. Complications are always possible when we're looking at these patients, so we need to be aware of the complications that go along with hemodialysis. Complications can include peritonitis, exit site and tunnel infections, poor diacylate flow, diacylate leakage on these patients. So we need to be aware. We need to be assessing our patient for signs and symptoms of peritonitis. Things that we might see with peritonitis include the cloudy diacylate outflow. These patients may have fever, abdominal tenderness, abdominal pain, general malaise, nausea, vomiting. All of those can be signs of those type problems. Again, we're always checking the site for those. Sometimes we just don't get the return. We put the diacylate solution into the peritoneal cavity. It doesn't come back out. So that can be a tube problem, those type things. Typically we'll roll the patients, move them around to see if it comes back out. So if it continues to be a problem, they have to go in to see the physician. Again, we can see leakage around the site. Again, that's something the patients would need to see their provider about to see what's going on. Best practice care of a patient on peritoneal dialysis include make sure you and your patient wash your hands. Make sure you're putting on sterile gloves and remove the old dressing and change the dressing as needed. You're going to assess the site for signs of infection. Always using aseptic care on these patients as you do that. And again, just the good routine wound care on these patients, taking care of that peritoneal dialysis catheter. Again, something that's used at home. Patients live years on this peritoneal dialysis. Again, it's a choice that patients make in looking at options for dialysis. Of course, the ultimate renal replacement is a kidney transplant. Kidney transplants have transformed the lives of many people, and I can say for my wife it has been wonderful. She's had a transplant since well, for 11 years now, and has done very well with the transplant. So we'll talk about kidney transplants. What we'll talk about with transplants is candidate selection, donors, pre-op care, intraoperative care, post-operative care, some complications, and also some of the different things that patients face when they go home with a kidney transplant. So candidates typically are pretty straightforward. We look at certain things to accept or basically say patients cannot have a kidney transplant. Typically, most patients who come are interviewed and talked to about a kidney transplant. Typically, we'll do it up to age 70 without any problems. It has been done above age 70 depending on the patient. But any patient that comes that has advanced uncorrectable cardiac disease probably is not a candidate. Typically, the transplant is going to make cardiac disease worse because of the medications these patients have to be on. Anyone that has metastatic cancer is not a candidate because there are so few organs out there, and we have to do immunosuppressive therapy. Metastatic cancer is just not something that's there. We also look at psychological problems, especially dependency type issues, drug use, and alcohol use, because those can be some of the problems. Every patient, or not every patient, but when my wife went through her transplant in Hawaii, she had to see a psychiatrist to talk about the things that would go on, psychological issues, some of the changes in body image that will occur after the transplant. So those are some of the things that's going on. They talked about other types of cancer other than metastatic cancer, and that's just going to be dependent on what's going on. Again, it's a greater risk for these patients. Even if they have had cancer, it's not present now. When you put them on these immunosuppressant agents, it just opens up that door for cancer to occur again. So beware, those may be some of the issues that you see with these patients. Donors can be living, related or unrelated. Can be non-heart-beating donors or cadaveric donors. All of those are possible. Now, living donors, when we look at organs from living related donors, has the highest rate of kidney graft survival. So related basically means brother, mother, sister, brother. Those type things are living related type processes. Those do tend to work better as we're looking at patients, simply because we see a better match with the blood types and the HLAs with these patients. But it does not have to be a related donor. It can be an unrelated donor. If we look at an unrelated donor, then we still have to go through that whole process of looking at blood typing, HLAs, to make sure that this is a match, a close enough match for those patients. When we look at any donor, they need to be greater than 18 years old, and seldom do we use anyone greater than 65 years of age, but it has been done. Again, seldom is the key word. We do assess that patient, that donor patient, if it's a living patient, for history of cancer, history of hypertension or kidney disease, and adequate kidney function for these patients. Again, these patients many times will have to undergo psychological evaluation to make sure, look at their motives. Do they understand what they're getting into, the changes it will mean for them in their lives? So a lot of that is really important as we do that for these patients. Again, the donor, my wife's donor, was an unrelated donor, a lady in our Sunday school class. Told her that she would be tested and donate. Both my wife's brothers were tested. Unfortunately, they both had problems that they couldn't donate a kidney. One had hypertension. The other one also has the autoimmune disease that destroyed my wife's kidney. So those are some things that they look at as far as those issues. But the recipient and the donor are both put under extreme psychological testing as part of that whole process. when we talk about some of the surgery, we'll talk about some of the things that the living donors actually have to go through. Now, the non-heart beating donor are persons declared dead by cardiopulmonary criteria. The kidneys from these folks are harvested as soon as possible after death. If they can't harvest them right away, these organs are preserved by infusing cool preservation solution into the abdominal aorta after death and basically removed as quickly as possible. Now, cadaveric donors, basically those are the patients who you see have irreversible brain injury and brain death, usually as a result of trauma. Typically, these patients are maintained on mechanical ventilation and on medications to ensure renal perfusion. And these kidneys can remain viable for several days in this process. But those are some of the types of donors that we see for kidney transplants. Preoperative care we talked a little bit about. Immunological studies, blood typing are all going to be done. An HLA match is looked at for these patients. All of that takes place weeks and so before the transplant to get things ready if it's a living donor. If it is a other type of donor, the non-heart beating donor or the cadaveric donor, all of the blood matching HLA is done, but all of this is done very quickly. The patients themselves have already gone through all this, so it makes it very quick. They're in a typically these patients are on a transplant list to see, and then basically once a match comes up, they are called in to the transplant center for those type issues. We really want to get dialysis done on the patient within 24 hours of surgery, so we have the better chance as we get into surgery. If it's a live donor, many times they'll do a blood transfusion from the donor to the recipient. Again, this is just to kind of prepare for some of those processes that go on with the immune process with these patients. So that may be something that you see going on with these patients. Intraoperatively, realize basically, typically there are two teams involved with these, especially with the living donor. You've got the first team that's going in to harvest the kidney from the living donor. My wife's donor, they actually ended up they do it by laparoscopically, which I find amazing, to remove the kidney from there laparoscopically. Did very well. The second team is there to do the transplant to the patient in those areas. Same thing if we're looking at the other. There has to be a team at the site to harvest the organ, and then a team there to transplant the organ for these patients. When we talk about intraoperatively, we kind of talked about this in some of the other areas. The patients receiving the kidney transplant, it does not go back where the old kidneys are located. Those are left in place. We don't go there. It's usually put in the left or right. I apologize. It's usually put in the left or right pelvic area. The renal vein, renal arteries are connected again to the areas in the pelvic, and the ureter is just connected right into the bladder there. So it is right there close in the bladder. It's usually pretty protective, but as we send our patients home, we do need to remind them about how close it is to the surface and to be very careful as they're taking care of this. One of the big issues that we see early on with these is seat belts going across there. The patients are usually very tender in those areas so we have to make sure we're advising the patients on those type issues. Postoperative care, these patients are typically on a special unit that deals with kidney transplants. They typically are going to have a large size indwelling catheter in place. Sometimes they'll do continuous bladder irrigation just to make sure there's no blood clots or anything that is going on. That urine may look bloody for the first hour or so. I will tell you, though, there's nothing more exciting than seeing that first few milliliters of urine coming out into that catheter after that transplant. That's just a wonderful sign to see, and those patients will get excited when they see that urine output going on. We want to make sure we're checking the urine output hourly for the first 48 hours. because one of the things that can happen if we see a decrease in urine output, it can indicate a problem with rejection, and so we have to make sure that we're monitoring that routinely. A daily urine specimen is sent off looking for any kind of infection, how the BUN, creatinine clearance, all of that is going. And of course we're going to monitor electrolytes on a routine basis for these patients. Again, we just like all post-op patients, we want to try to get these patients up, moving as quickly as possible, preventing pneumonia, preventing DVTs. All of those are the routine type issues that we want to take care of these patients. Now, don't forget, there's also care involved with the patient that was a donor. Typically, the donor patient has more pain because of because of the location of the kidney, having to go through more muscle to actually get that out. We still want to monitor their urine output, monitor their electrolytes to make sure that one kidney is taking over and is doing the job for them as well. So both patients have to be monitored. Now, complications. Typical complications can be acute tubular necrosis, thrombosis, renal artery stenosis, infection, urinary tract leakage because the anastomosis didn't take place. And the biggest concern, all of those are pretty easily taken care of. The biggest concern is rejection. Remember, we're putting a foreign substance into a body, so rejection can occur on these patients. When we look at rejection, we're basically looking at a hyperacute rejection. We're looking at acute rejection and chronic rejection. When we look at the types of rejection, again, that's why we're monitoring these patients so much. That hyperacute rejection usually takes place within 48 hours after surgery. What we're going to see is increased temperature, increased blood pressure, pain at the transplant site. May see enlarged tender kidney. These patients may be lethargic. You may see that serum creatinine, BUN, potassium levels all kind of going up, and fluid retention. Typically what can happen is if it is a true hyperacute reaction, the transplanted kidney has to be taken out. They will try other things. First off, they will continue to work with that patient with the immunosuppressants, those type of things. But if it's a true hyperacute reaction, that kidney will come out. With my wife, she began to have some tenderness, had some problems with a little bit of a fever. They actually went back in and did a biopsy to check for that hyperacute reaction. Thank the good Lord, it turned out not to be a hyperacute reaction. So she actually, the kidney calmed down, everything went well. Now, these patients, even though they get past that first 48 hours, still have issues. They can have acute rejection, which can occur anywhere from 1 week to 2 years post-operatively. But for most patients, it occurs in the first 2 weeks. What we see with them is basically oliguria or anuria. We see a low-grade temp around 100. We're still going to see increased blood pressure on these patients. So typically what they're going to do is just increase those dosage of immunosuppressive drugs and continue to monitor that patient. They will eventually try to come down on the dosage of the drugs for these patients to make sure that they're doing okay. Chronic rejection occurs gradually over a period of months to years. So what you're seeing is a gradual increase in the BUN and serum creatinine levels, fluid retention. So these patients are just basically going back into that chronic kidney disease type process for these patients. As these patients are discharged home, they're going to be on immunosuppressive medications. Cyclosporin is one of the drugs you may see. Typically, they're going to be on steroid therapy, anywhere from 5 to 10 milligrams per day of steroid therapy. This is why in a lot of these patients, they talk to them beforehand about body image. Go back and review your problems with increased steroids, with the fat buildups, those type of things, adipose buildups in these, increased risk of cardiovascular disease, increased risk of bone loss. That all goes along with chronic steroid therapy in these patients. The patients need to be aware of that's going on. Education is very important. These patients need to understand how important it is that they take these medications on a routine basis. And it's not cheap. These immunosuppressive medications are very expensive, and so they need to understand. Most of the time when they have been on dialysis, they have been on Medicare. Medicare is taking care of all of that. But once they've finished the kidney transplant, Medicare plays out in about 6 weeks afterwards. So now they are responsible for these medications and the purchase of these medications. These patients need to get regular follow-up care, making sure they're seeing their transplant team on a routine basis, their regular provider on a routine basis, because we still need to manage any other diseases. They have diabetes, they have hypertension. All of that has to be managed very, very closely in these patients. And again, we've talked about this a little bit earlier, UTI prevention, and talking to these patients about that because of the decreased distance from the bladder to the kidney, the risk of pyelonephritis goes up, so urinary tract prevention is very important. Most of these patients are told not to go swimming, especially in lake water, because of those type issues. Again, they're talked about because of the immunosuppressant, staying out of the dirt, and different type things that we talk to about our patients who are immunosuppressed. So be aware that these patients fall under that same category as anyone that's immunosuppressed. That's all I have on chronic kidney disease. I hope you have a great day.